we're going to be entertaining questions through that chat box. So if you see a tab at the top that says chat, you can click on it to make sure that that window is open on the right column of your screen. And then right below that, you'll see the option of either sending to all participants or just the host, and a place to actually type in your question and hit send. You can also, if you are identified on the system, raise your hand to ask a question, but that means that you had to have logged in or dialed in after you've logged into WebEx. And so because of the numbers, I think, today, I'm mostly going to try and attend to the chat box, but if you feel a pressing need to speak, please go ahead and raise your hand and we'll try to get to you. So with this, I am going to pass this off to David. And David, can you drive these slides?
Let's see, I'm about to change to the other slide. Can you all see that change?
Do people see the new slides?
They can't talk. So
okay, hold on. Let me unmute. Okay, you've all been unmuted. People see the new slides?
No.
I think our host needs to switch to what's shared. While she's doing that, I'll get started. I'm going to go ahead and mute and then
Got it.
Yes.
Got it.
Got it.
They can't talk. Yeah, then I'm going to mute everyone and then unmute you real quick, okay?
Great, thank you.
Go.
Okay, great. Thank you. So it's a pleasure to talk to you all. I'm pretty thrilled with the number of people who are able to participate using this technology. It really makes a big difference to be able to reach you all. I'm sure you're in the midst of your busy days. Actually, that's a significant topic that I'll talk about, the sort of exigencies of day-to-day work with people, caring for people. So I want to thank the California Healthcare Foundation for setting this up, and Sophia and Nandi and Jan and everyone, because it's really a thrill, and also Stu and Rini and Sigmi for joining. So I am going to talk about our experience in basically working with people at risk, usually frail older adults or those with multiple chronic conditions, basically anybody who has significant complex healthcare needs, and the way we reorganized healthcare teams in primary care and gave additional health information technology to especially care managers to support these people in their goals and aspirations, and their families and caregivers, of course. Most of the research that I'm going to talk about was funded from the John A. Hartford Foundation, or AHRQ. Intermountain, where much of it was done, is a strong proponent, and as well as the National Library of Medicine. And I leave our website there because if you want more information, you can just go to that website and find much of it. So in general, Care Management Plus is a model that really focuses on teams and enables them to really think prospectively, proactively about populations and at risk, and really try and personalize their care. And when we thought about this as it was started in Intermountains in the late 90s, early 2000, we really thought about, well, we need to reorganize roles and provide training that really focuses on the priorities of the people, their preferences, the responsibilities and skills, and that what we found out really quickly is that it can get very overwhelming, especially because there's so many often competing or different elements of our very fragmented healthcare system, and we use technology especially trying to help them make better use of technology to help the model go forward. And I'll talk about our outcomes, and then we'll spend a fair amount of time talking about the dissemination and the training and the stepped approach we use and the adaptability of the model, mostly through our dissemination partners that are on the phone. So I don't do this alone. There's obviously a lot of people on our team, and we're still really in multiple locations at Oregon Health and Science University, where I've moved, and then there's a team at Intermountain Healthcare, as well as we have people really from all over that help us to try and adapt the model as times change. I should note that there's actually a training going on right now in Portland, Oregon, so many of these people are training, doing another training, so they would have liked to join, but I will relay their questions on. So I'd like to start with a case, and the reason I do this is because I think it helps bring into focus really what the purpose of this endeavor was. And so Miss Vieira, a 75-year-old woman who has 5 chronic conditions, comes to a visit in her usual care setting, her primary care setting, and with her caregiver. And she basically, these 5 conditions, all of which are potentially important on their own, when you add them up, they're really more than just those conditions alone. For Ms. Vieira, people with multiple chronic conditions usually come to visits with multiple problems, on average 5 to 7. And these, as I'm sure you're well aware, none of these will be solved in the immediate office visit. So, sorry about that. My slides are changing here. So the technology has taken over. So do you see, if somebody could type in that they see Ms. Vieira and her caregiver come to clinic, is that the slide that you see at this time? That would be helpful. So there's basically 5 to 7 problems, none of which will be solved. Okay, great. So I see that the slides are not changing. Thank you for pointing that out. They're going to fix that. Fortunately, you haven't missed much in terms of the content. I try and keep the slides brief. Now I'm the presenter. So now do you see a slide that says case? Thank you. Okay. Technology, how much fun it is. So these 5 conditions won't be solved, and in fact, the issues that Ms. Vieira comes with also hint at additional risks for her, including the last one on this slide, a recent fall, which we all know is a significant indicator of future potential hospitalization and declining function. So what is even more difficult is in the usual primary care office that there's the doorway or doorknob conversation, the hallway conversation, where the caregiver says he is exhausted. It's become a lot more to try and manage everything, and then money's running low. There's financial concerns. And so what we set out to really address is how can we address these issues with the team structure we have, knowing that it wouldn't be addressed solely within the team, but really thinking about a more proactive system. Well, the first thing we really came to is thinking about things a little differently. Instead of thinking about her as a set of conditions, of course, we thought about, well, what are the real risks for her and what's most important? And her conditions play into that. This slide on the x-axis shows as the number of chronic conditions increases, so too does the percent with activity or functional limitation. So with 5 or more, about 2/3 of people have functional limitation. This ends up being the predominant driving force for cost in many cases for these people at risk, as well as mortality. So trying to prevent functional loss or limitation is really a crucial element in terms of keeping people out of the hospital, keeping people independent, keeping people from needing to go to the emergency department as frequently, as well as keeping them happy. because that's such a significant element of their life experience. So what have people done in the past? Well, really, I call that heroics. Really, because as those number of chronic conditions increases, so too do the risk and coordination needs, and they don't just increase linearly, they really increase exponentially. So with 5 or more chronic conditions versus none, 90 times the risk of hospitalizations. You fill 10 times as many individual prescriptions. You see many more providers. And for the primary care teams, they're already overwhelmed in trying to manage the preventive and chronic illness needs in their own panel, 18 hours a day for just those 2. And when you add the acute care elements, obviously it's getting close to 24 hours, which, we're all superheroes, right? This is the heroics, but really not a sustainable model. What was interesting, though, and sort of highlights the functional issue, is that studies came out at first saying, well, let's try and maximize their quality scores. And what we found is, yes, there are process quality scores like getting tests done, getting a vaccine, were actually better in these people with multiple chronic illnesses, but actually they still had these worse preventable hospitalization, preventable in quotes, because they're ones that are likely to be associated with the chronic conditions and ambulatory care from previous studies. So the intervention that the teams came up with, and this was started in 7 clinics in Intermountain Healthcare, were really pretty straightforward. The clinic was able to refer any patient for any condition or need felt to have ongoing complex needs, with a focus on certain conditions known to be problematic: mental illness, diabetes, cardiovascular disease. And then the care manager would work with that person to assess and co-create a care plan, and then act as a catalyst to see that plan go forward, and then be a structure within the clinic to really help when crises arose, or to make sure that they had easy access when they needed it. And then technology was built actually at the request of the care managers. So they quickly became overwhelmed with the many elements, and so they needed a way to access and add to the care plan, to remind about best practices, not just for the many preventative and chronic illness needs, but also for the things that they felt they really needed to follow up on, the historical Post-it notes that they used to leave all over their monitor about, boy, I can't forget this. So a way to tickle themselves is what we call it. And then for communication, a way to really document widespread communication with many different participants in this person's health and well-being. And then evaluation was done for the population that they were following, with interaction between them and the primary care providers. They were embedded in the practice, so they just had to walk down the hall and talk to them. And then there was also ongoing evaluation with key process and outcome measures to help make sure that there's still a focus on quality. And this was in a setting in Intermountain Healthcare that had built its own electronic health record system, and we had to build additional technology on top of it with a very strong quality focus. So we rolled this out in 7 clinics, and then we compared these in a controlled clinical trial to similar patients, the ones that were referred in those clinics, to similar patients in our control clinics. And we found some very interesting results. First, for the just over 1,000 patients who are over 65, we found the care-managed patients were less likely to die at 1 and 2 years, especially if they had multiple illnesses, including diabetes, the significant prolongation of life. The hospitalizations were significantly reduced, about a relatively just over 20% at the first year, and then 40% at the second year. And then we looked at other outcomes that I think could really be described best by the triple aim. And so that includes the quality scores. For instance, diabetes scores improved, as actually many other studies have shown, as did depression outcomes in terms of reduction of severity of depression. So we didn't lose the individual diseases, but we were able to take a more proactive, individualized approach. As well, people love the system. They like that hands-on attention because the care managers were introduced usually by the provider. They felt like they were part of the team and they weren't being sent somewhere else. And the providers loved it as well. They really felt that it helped them achieve what they wanted to. And then cost obviously decreased significantly. It's the cost decrease is just under $2 saved for every $1 that they spent. So Intermountain, after the study, doubled the number of clinics from 7 to 15 that had this model in it. So we stopped and we said, well, what were the lessons from this? Because we wanted to be able to share it. And so first is obviously the people. The people who are seeking care, I'll call them the patients and their families and their caregivers. They're really taught to self-manage. They're really empowered to express their priorities and preferences and make sure that those are acknowledged in the care plan. And then they have a guide in the system. The care managers receive special training in education, motivation, and coaching, especially motivational interviewing, sort of behavioral change models. There are disease-specific protocols that really the whole team participated in. And then there are geriatric-specific elements like fall risk assessment and intervention and cognitive screening and caregiver support for the issue that Mr. Vieira raised, for instance, and then connection to community resources. I have a question. Is a care manager an RN? In the original studies, we started with 6 of 7 RNs, and then we moved to 7 of 7 partway through just because of staff changes. And we train about 90% RNs. Other people can do elements of this, and we're pretty flexible. Social workers for certain populations that have very high psychosocial needs. I think every profession sort of brings its strength as well as sort of potential weaknesses that need to be considered as we go forward. I mean, it's really a team-based effort. So the curriculum content we worked on quite a bit, and I'm starting to segue a little bit into the dissemination phase based on what we learned. And so we developed, initially the curriculum was done over a period of about 2 years, really developed as part of that original study. And we've rolled it up into essentially 1 or 2 days in person, where you get a sense of the role, the technology elements, how to better use technology, and a lot of in-person motivational interviewing, case role-playing, real-playing, as our motivational interviewing person calls it. And then we have people go back to their jobs, and then we have this ongoing online component that's about 10 weeks, where we talk about the chronic illnesses and people bring cases, and the idea is as experiential as possible to maximize their ability to actually put this into practice at their place. For technology, what I really hoped to be able to do with this, since I'm an internist and medical informatics person, is make it like it was in Star Trek 4. So I don't know if you remember this movie, but on the left is Scotty, and he's gone back in time into the 80s, and he's talking to a mouse. And I'm the guy in the middle. I'm befuddled by this. I'm like shocked. What are you doing? But it's really telling us something that the technology needs to be as easy to use as possible to make it, to really help us focus on what's the real needs and priorities of these people. And so he was used to just talking to the computer. Hello, computer, please do this. So we're not quite there yet, but we did go out and build a series of tools on on top of the electronic health record system now through a new trial that we have more connected to it. But we found this big gap. So one of the things we did in the immediate period after the initial study is say, well, how would we replicate the technology part? So we went out to teams that had electronic health record systems, and we said, what do you need to do to complete care management to be really successful at that? We talked about that. And then we asked, well, how does your IT help or not help? And we found 117 things they wanted that were not currently part of their IT system, their EHR system. And you can see the categories: care planning elements, reminders, communication, population-based elements. These were all missing, and I think this probably resonates with people who've used these systems. They're really for billing and documentation, which makes, economic sense, but may miss the point for these people that we care for. So what did we learn as part of this? So the slides I'm going to show are not, they're from a newer system, so they look a little nicer, but they're mostly the same function. So the first thing I said is, well, we want to be able to quickly drill down into the quality measures and get a synopsis of them. And so we built this dashboard that also compares teams based on their success to have educational competition a little bit. But what they really wanted was say, you know, when we think about these people, some of them this is not really appropriate for, and I keep getting the same report again and again saying, call these same patients because they're not getting their hemoglobin A1C done or it's high. That's really not their priority. So we built a really easy way to interact with those reports so you could exclude people from a particular measure or all diabetes measures because that wasn't their most important component. But you could also refer them to the care manager if they weren't being seen because this was a good person to follow up on. Really the heart of the care manager's workflow is a tickler system. So I mentioned that it reminds about best practices. Many of the reminders they wanted to set were not sort of traditional clinical decision support, the sort of reminders about getting tests done or that the hemoglobin A1C was too high. They were things like, I need to meet with this family in the next week. It's very important to discuss that care plan. And so we built a workflow, a sort of task management system where that was facilitated. It also brings in some sort of high-yield protocols. For instance, at OHSU, this brings in the hospitalizations and ED visits, so then that becomes a task to follow up on for telephone or the MD office visits so that they can co-attend. The idea being that these are the really high priority elements that require follow-up. And finally, to really condense or reduce the complexity of the needs of these people and to represent them their health care needs, at least in a more understandable format, the patient worksheet was developed, part in the original study and certainly has been continued on now. For those of you following meaningful use for electronic health record system, this is a clinical summary that would be similar to that, and we found that to be extraordinarily important. Basically, it's a filtered view of the system that consolidates diagnoses, medications, the goals they've set, the functional status, some assessments, and then for all the preventive and chronic illness needs that are followed in the system, basically prints those out as care actions. So doesn't interrupt the workflow, but allows people to have conversations about, you know, here's what's recommended, what's important to you. So with that training and the IT components, we got a second grant from the John A. Hartford Foundation to basically go out to sites and help them figure out how to replicate this. And so we've actually worked close to, with the training today, about 175 clinical teams. And so we'll let them express their experience in this regard. But they're really all over the country, and actually many of them have come, they do this really well themselves already, but they want to learn more from us. So it's been jointly beneficial to have an ongoing learning collaborative. So what we've learned immediately from that, and then I'll turn it over to Stu, is that it's really a stepwise approach. We're really talking about transformation of a healthcare team and the sort of services they provide. And so one of the things we learned early is we have to talk to them and then see where they are and then have them fill out sort of a readiness assessment. How will the system be paid for? And because reimbursement is often not aligned for the care manager's activities. They're literally doing things that are unreimbursed in many systems. And then to create a plan with them to help them better use technology to be flexible and adaptable, but really highlight the core components of the prioritization and goal setting and other components, as well as the better use of IT. And then have training and then do some follow-up afterwards. For instance, 6 months after we ask them, do you use these components? And in fact, most people have at least tried them out, made use of them, and many, more than half, use most of the components regularly. So I'll turn it over to Stu. I will say we're going to have a little bit of a transition here because I think he's calling in from Phoenix and may not be able to get on the computer, so we might need to unmute everybody if we can't find him.
So I've just unmuted everyone. Stu, are you out there?
People do say I'm out there. I'm on phone, but I'm also on WebEx. But I don't think that you're hearing me. You could try muting everybody and see if you can hear me still talk. But I'm on both actually.
Okay, let me try that. I'm gonna mute everyone and keep talking, and we'll see if we can start talking.
Okay, me talk? No way.
Okay, so Stuart, I have to unmute all in order for you to speak. So go ahead, and the rest of us will try to keep quiet and avoid extraneous noise.
Okay. So just to give you a little bit of background, the way we discovered David and the genius stuff that he's doing out in Portland is that we were on a site visit up to the Peace Clinic to look at new innovative approaches towards high-risk integrated clinic setting. And we were going to Portland, and I had heard about David because of my work with Impact Project and Hartford Foundation that sponsored both. And so we were on collaborative innovations together. And so we went to see what they were doing, and we were really quite impressed that they had looked at care management in a very unique way that was both adaptable to the staff model as well as to the IPA, and that we could learn a heck of a lot, both from the standpoint of process and IT. Initially, it really looked like it was an IT issue, but as I learned more about it, it seems like it was much more significantly a process issue that was just supported by IT. So a little bit about Healthcare Partners. We're a large group in Southern California, Las Vegas, and Florida. We take care of about 750,000 patients, about 150,000 seniors, 100,000 of those in Southern California. We're about 50% IPA, 50% staff model, and are highly concentrated, at least in California, in Los Angeles and Orange County. By the way, my WebEx has all the slides have disappeared. Do you guys know that? Oh, okay. There we go. We're physician-owned and driven. We're not owned by a big company. It was started by Bob Margolis and then has grown through mergers and acquisitions as well as additional physicians joining us.
No way.
Way. Shall I continue?
Yeah, we'll keep trying.
The biggest issue today, as with everybody, is that we've been used as the model for ACOs as new health legislation, health reform have rolled out, and so we've been trying to not only adapt the managed care learnings that we had to managed care as we know it, but also to the fee-for-service delivery system and make it work in there as well. That was really a mandate of being able to do things as effectively, if not more effectively, while driving down costs both to government as employers as well as patients, and have at least equal or better results. That also is mandated that we continue to broaden the target populations that we involve with innovative care management. And so what drives this is really sustaining commitment to quality and make sure that we're getting better outcomes and better quality, both as far as hospitalizations, ER utilization, P4P measures, 5-star, and the like, but also as importantly as anything else is patient satisfaction, patient access, because those are the most salient points around ACOs, because that's going to get what drives people into participation in the delivery system. And then also build systems that account for doctors' wide variation in practice. And so when we were all staff model, it was pretty easy to control physician behavior. As we broadened the IPA, it became a little bit more challenging. As we have a very broad IPA at this point, it's even more challenging. So we assume that physicians are not going to be practicing in the style that we hope. Put lots of incentives in place to try to ensure that they do, but build infrastructure around them to guarantee that the patient will never fall through the cracks. We also look at a hub and spoke mentality to doing this, and so as we've gotten larger and larger, we are adopting the Billy Bean theory of baseball, which is playing small ball. And so we've divided the company into small geographic pods, organizing every delivery system around a staff model, and then that becomes the hub, the spoke being all of the IPA physicians. The hub also then contains all of our high-risk programs, and then we disseminate out to all of the IPA doctors all of those innovations in care management. So not only do we now have, ever since we started collaborating with David, have care managers embedded in our staff models, but also now starting to embed them in the IPA physician offices, so that we're guaranteeing improved quality and improved outcomes across the board. We're also trying to ensure that the managed care administrative functions get more centralized, not decentralized, but decentralizing practice management and other innovations to support the IPA physician to, again, drive down costs and increase physician and patient satisfaction. And then finally, trying to implement EMRs throughout the system as well as care management tools, in addition to the portals that we have for both patients and physicians that drive similar kinds of delivery systems throughout and reduce the variability. And these portals are interactive where every physician can then view the clinical viewer for every patient. That not only gives you the list of all their diagnoses, all their medicines, what care management programs they're on, but also all hospitalizations, hospital consults, specialist consults, and anything that's available as far as summary reports out of EMR, if they're on an EMR, or scanned reports that are in an EMR, that accounts for that. We also use 3 EMRs simultaneously so that we can integrate the 3 EMRs that are part of the delivery system. The slide that you showed just before this one was the one on our approach to risk stratifying patients. And so what we do is we try to build the appropriate intervention for the most appropriate patient. So the highest cost, most complex patient is the person who's put into hospice and palliative care programs. The next level of patients, both in cost and complexity, goes into our home care programs, all of it being team care, comprehensive care clinics and post-discharge clinics in the next level of patients, complex care management, disease management next level, and then primary care support and patient education in the last level with an ESRD medical home going along that. And both the cost of the intervention and the cost of the patient match itself up so that we get the right care to the right patient at the right time. Given all of this, David's system of care management plus became more important because we couldn't just manage Mrs. Jones, who was really the very difficult and challenging patient, but we had to be able to reach out to all patients at all times and catch them as they're transitioning in care. And that transition didn't mean from necessarily just the hospital to the home, but any time there was a handoff made in the system. That transition could be from PCP to specialist, specialist back to PCP, from outpatient to inpatient, inpatient to SNF, wherever that transition from one high-risk program to another. And so we took David's training around care management plus, and we also took his IT knowledge and built it into our own IT program that took all of his technology, and we then stylized it to ourselves to make it into something called CICIS, and embedded the care managers into the site. That's something that should have been apparent to us to do a long time ago, but it wasn't, and only now we're going to truly site-based care management along David's model. Some of the things that he taught us in training, including motivational interviewing for all care managers, outreach, graduation after 6 months, transitions between ambulatory care management in the site to higher levels of programs, the things that we got from his from participation in his wonderful AHRQ experiment. So we started this out at 2 sites, a downtown LA clinic in Dixie Knolls, had lots of starts and stops. Didn't work so well at the beginning, mostly because of our trying to adapt our rather cumbersome but integrated system to new things that he was introducing, and then redesign our care management system. So we enrolled all the patients that we currently enroll in our very high-risk programs, and then took the next 10 to 20% risk patients below that and enroll into Care Management Plus. or Adaptation and Care Management Plus. We got the care managers, Tanya Jackson and Sam Forte, very busy, although it took us a while to do that, just again because of infrastructure issues on our part, and then integrated information technology to that. And what we ended up finding was really robust changes in both efficacy, cost reduction, reduction of hospitalizations, reduction of emergency room, patient satisfaction, and physician satisfaction, where now every staff model as well as IPA officers are clamoring for us to actually adapt and put this into those sites. And in the new budget year for January, we're actually transforming the entire system site by site to follow the learnings from this participation.
Thanks, Stu.
Other things you wanted, David?
No, that's great. I want to give Signe a moment to talk, and I don't know if we have Rini as well.
I'm here.
Okay.
So I'm going to mute everyone, and I'm going to unmute the two of you, Signe and Rini, okay?
Okay, sounds good.
So if the two of you, can, especially Rini, can talk about your experience, that would be great.
Talk about our experience. When I've been with Klamath Open Door for almost 9 years, and when I came on, they brought me in as a care manager and had the plan of developing our own care management program, and it didn't get a real good start. And I found that, I was being pulled in a lot of different directions to do a lot of different tasks. But when Care Management Plus kind of came into our lives, it really brought the care management program back into focus. We had some challenges along the way in terms of getting, buy-in from the providers and getting their full support and really developing a degree of trust in bringing me into the patient care team and knowing that I was going to do an effective job, or trusting that I would do an effective job in helping to manage these patients and some of their needs that really needed to be taken care of outside of that 20-minute physician visit. And it's just been a real beneficial program. I'm one of two of us now, but I'm transitioning out of the role, so we will ultimately just have one care manager in the clinic, and that's what we've had for quite a while. And we see a variety of patients, everything from diabetes to, chronic disease management to assisting with pain management, lots of, assisting with social needs. It's really a multifaceted kind of care that we provide, but we do have a lot of resources in the clinic too that we bring in to just meet all of those needs of our patients. I don't know, what else, David? What else would you like to know?
Well, I think in the interest of time, maybe since you're on the phone, Klamath Open Door has been a huge, they've adopted the technology, you use it to drive your workflow.
Right.
So it might be helpful just maybe to get some questions, or we could answer some questions that people have. Does that make sense?
That works for me.
So people can either type them into their chat function, or if you're on WebEx, you can try raising your hand, and I think I should be able to see you to be able to unmute you to speak.
Yeah, so I have one. Is this a web-based information system? And the technology and the integrated care coordination information system, which is sort of our newer, basically we took 4 EHRs to make it more sustainable and take nightly feeds from them and process the data to sort of take the core set that's really important for people with complex needs and put it into a .net application that is accessible via the web. We've made strides towards even a tighter integration. Obviously, the legal and sort of other issues are the predominant ones in many of these sort of exchange things. But at OHSU, for instance, we can send a note back into the EHR from the ICCIS system. So it is web-based, yeah.
David, do you want to manage these questions, or do you want me to help?
You can help.
Okay. So I see one hand up, which is Ahmad Kadri. I'm going to unmute you real quickly to ask your question, and then we're going to get to the typed ones, okay? So...
Can you hear me?
Yes, I can.
I'm interested in knowing what ratio of care manager to patients in the complex case management or care management program for both senior and commercial. Imagine it's different for the different populations. Like, how many care managers do you have per complex patient?
Well, David, can you answer that in terms of an average in the different clinics that are involved in the study? Because as I said, there are 2 of us right now for our entire clinic.
Which is how many patients are handled, how many complex patients are handled. We're struggling with that question and trying to start our own program, and
right.
Budgeting purposes and planning would be nice to know what your experience is.
Yeah, I'm afraid I don't have those numbers. I did not take a look this morning at what my current count for patients in my case managed practice is. As I said, David, do you have an idea of an average?
Yeah. So there's a report in the system that will actually give this, and it's a little bit tricky to answer that for Klamath Open Door because, I mean, you guys are very spectacular, and so when they enrolled over 1,000 patients for these 2 care managers. I mean, this is a health center in rural Oregon that serves the underserved. So most of them have complex needs, and they really do a spectacular job. In general, I think in our studies looking at the sort of cost benefit for the complex patients, usually around 200 actively followed patients, you even out sort of the cost of a care manager. And also it turns out around that number of really active patients, they start to feel really busy even with the technology to help the workflow. And 200 in our original study there were 350 per average, but some of them were more on maintenance, and so 200 and 250 seems to be the number that we've seen a lot in actually not just our experience but others.
So if it helps you to know, we have 8,000 medical patients, and of those then we've signed up 1,000, and I think really that we could probably sign up many more had we the access to do it now that the providers have bought into the system. But Reni's too busy.
Thank you.
I think one of the key questions that's related to this is getting a better understanding of perhaps exactly what you talked about, which is the kind of relationship between the provider and the nurse care, Reni's role as the nurse case manager. And from what I understand, Dave, this varies a little bit. Maybe Klamath can talk about how they do it, and maybe you can talk about some of the variations.
Do you have any access to a mental health professional or a clinical pharmacist in the team?
We don't have a clinical pharmacist, but we do have a psych mental health nurse practitioner on our staff.
And what's your role? How would you describe your role, Reni? I mean, what is your core functions with the people that you see?
My core function, I would say, really falls into helping people align with their disease process and learn self-management of their disease. So I'm kind of a coach and an educator and a resource and somebody who passes, who finds other resources for patients. As I said, there's a big social component to my work here, as well as or filling social needs, as well as helping the patient to learn to manage their physical needs. Does that make sense?
Yeah, that's what we see a lot in many of the practices, is sort of this really important role of the coach and help align and educate. I think for many of our clinics, they play this role of sort of helping to understand where the person is. I think Ann Larson, who's actually doing a training right now as our care manager from Intermountain Healthcare, she always talks about being a detective, trying to figure out what's really going on with this person, and sort of being a problem solver where that's important, but really taking the preferences and priorities of the people and sort of figuring out, and then also bringing in the experience of the medical and disease and other things that may weigh in on those, and then sort of coming up with a way to move forward. And then you mentioned resource, connecting people to resources, and a lot of our care managers play that role. Are there other? There's lots of questions.
There's a whole slew of questions. So, David, I think one of the other themes that came through, as there are several questions on this, is trying to get a better understanding, I think, of the scope of what the care managers are taking on, and in particular the role of preventive services versus focusing on the complex conditions, which is a semantic difference, I think, but maybe Rini, you can speak to this a little bit. And I'm trying to find if Fran is on the call. I'm going to unmute all. Fran, are you on the call to talk from your healthcare partners experience? I'm not finding her. Okay, so I'm going to mute everyone and unmute. Rini and Senia, you can speak some more along with David on the issue, though, of the kind of preventive and complex care aspects to the job, if you will.
In terms of preventive care, I think I really have, I can't say I'm not involved in that at all, but I think really the complex care, the long-term chronic needs are the things that I find more often directed to me. I'm kind of on the fringe involved with, follow-up for preventive care, in terms of, following up with mammograms and recalls and women's health care issues. But really the greater majority of the job is spent at looking at or helping patients with those complex chronic needs.
And David, I think you answered this before, but there's a lot of questions as to whether or not in your model the care managers are RNs only.
Yeah, so we do not mandate that they're RNs. I think that there's most of them have been RNs because of the excellent perspective of RNs and sort of combining understanding behavioral and holistic things with a certain set of disease experiences and that. But in other places, they've been social workers. Actually, one of the care managers, one of our great care managers at Healthcare Partners, who's since moved on, it was a social worker. And I think that it really depends. And then somebody asked about MAs, and in very small clinics, I think you start to really talk about scope of practice here, but sometimes MAs really partner with a provider who has a little bit of time to help manage sort of the more complex things. And we've actually had some, in very small rural clinics, some excellent experiences with that, so the coaching can help. Tom Bodenheimer's really worked on a sort of health coaching dyadic model where it's the MA plus the provider, and the MA does a lot of the health coaching type elements. So I think that works. I mean, the IT can work for anyone. It's just where it falls in terms of ability. Somebody else asked who determines who should be care managed, and I hear some other things. I actually see one also that the caseload is smaller for some other ones. Who determines whether a patient should be care managed? This is a crucial issue, I think, that we all face. In original study, it was really the provider. And what we found is there was a variety of results with that some of those patients you saw immediately the cost savings, but there was a lot of re-education and then sort of honing down to the practice. So usually what we recommend now is you can identify a high-risk list, but you're going to miss people. I mean, risk stratification probably with just diagnosis codes or even diagnosis plus prior cost identifies less than 50% of the variation in sort of increased costs for people. So, and utilization. So you need to be conscientious that you don't miss people who are at the brink of functional decline. So that's usually what I recommend for that.
David, can I add some? Oh, I'm sorry. Can I add something there too? More than just the provider, we've also found that the support staff is really helpful in identifying somebody who's at risk. And again, a lot of times that comes down to the risk is identified through that kind of social need thing. But it's our medical assistant staff who might realize that there's a need in a patient that the provider didn't pick up on or isn't aware of yet, and they'll make that referral to case management.
So I'm realizing that we are at the end of our hour, and what I'm going to do is we're going to continue to record this. I'm going to give us 5 minutes more for a couple more questions. And for those of you who can stay on the line, great, but if not, we will be sending out a follow-up email with the recording of this so that if you miss the last few minutes, you can still listen in. And just a quick plug that we'll be having another call in 1 month at the end of February, and it will be about the integration of depression care into primary care, and there may be a fair amount of interest on that issue as well. So, David, I'm going to ask a couple more questions that seem to be summarized here. One is, there are several questions about when and if a patient can be discharged from care management, kind of what is the length of time in the program, and how do you determine when they can be discharged from the program?
Yeah, actually, Rini and I have had this discussion in the past. I think it varies depending on the population that you serve, and discharged is probably a strong word. The goal is that the person can manage their illnesses on their own. They're sort of in maintenance mode, but you're still available as a resource. And so there is some benefit to recognizing that people have changed status in that way, and people do. I mean, people really reach a trajectory where they don't need it at the intensive care. I mean, they still need health care, but they struggle. And I think some people sort of need active, ongoing active care as well. So, it is possible. It's something that we actually try and highlight, because the other thing is that if you're working much, much harder than the person, then, for most cases, and you really need to look at, are your efforts most aligned. That doesn't mean you're discharging them, but it does mean that you might need to sort of reorganize the efforts. And so we make ways in the system that you can sort of put them on different care management status that try and capture those elements, and then you can work with them in different ways.
Absolutely. You can count on most of these people, especially if you're seeing them for chronic conditions, that you may see them frequently for a while, and then they're more or less stable and they're doing okay on their own, but you know that they're going to cycle back and see you again. I don't have anybody that I've technically discharged other than people who have transferred from the clinic, or obviously those folks who have passed away, but otherwise they stay on my rolls.
David, there's a couple questions about managing the cost and the payment for complex care management, and I'm thinking it's a hard question to answer, but maybe you could talk about the different types of settings that the program's been implemented in and how it's funded. Would that work?
Yeah, that's actually a core part of our readiness assessment, because we consider that a risk. So I should say that as part of our new HRQ study, we actually randomized to 2 different reimbursement systems, a pay-for-performance system and actually a care management system where we specifically recompense them for the kinds of activities that Rini was describing, motivational interviewing and coaching and education and assessment, and trying to see, is there a system where you can specifically recognize those skills, those competencies as they're enacted, but that you're not sort of limited to the visits. So mostly what we see now are a couple things. One is people do a pilot and they pay for the care manager in the clinic, or they pay for some aspect of that. That's actually happened quite a bit, and it's sort of ongoing in a number of settings. That's probably not, unless it's multiple payers, it's hard to send that out. A lot of people use this as sort of a core of a patient-centered medical home, because there's a lot of the components, especially if you're accountable to them, where it ends up being very valuable. Obviously, Sue talked about if you're taking risk in terms of capitation and you can, incentives are aligned, you can keep them out of the hospital. That's another way that people have done it. So as we talk about, for instance, virtual integration through accountable care organizations, that's another way that people have really thought about that. So it's really varied, obviously, but that's something I think that's really important to identify, and that's why we ask people up front.
I think we're pretty much at the end of our time, but I really, really want to thank everyone who's dialed in. We'll take a look at some of the other questions, and if there are other issues or other things that we can try to send out as part of our follow-up to the call with the recording and the PowerPoints, we'll do that. And a special thanks to Dave and Stuart, Dr. Levine, and in particular Rini, who really tried to give us a much better flavor of what they're doing and how they're doing it. So little virtual round of applause with no one being able to be heard. So thank you very, very much, everyone.
You're welcome.
Bye.
Bye.